we are now core into the ECG, and we have already discussed what are the normal parameters that we see to interpret an ECG, right? So, to interpret an ECG, we see rate, rhythm, axis, the P wave, PR interval, QRS complex, ST segment, QT interval, and finally we give our report. Okay, we generate our report. Okay, so what are the parameters that we see to interpret a normal ECG, right? Write it down. So first is rate, then rhythm, then axis, rate, rhythm, axis, P wave, PR interval, rate, rhythm, axis, P wave, PR interval, QRS complex, ST segment, then T wave, then QT or QTC. Okay, so these are the parameters that we see in an ECG. Okay, so first thing is to determine the heart rate. Okay, so generally, how can you calculate the heart rate? How can you calculate the heart rate generally? How? Yes, simply by calculating the pulse rate, right? Simply by calculating pulse rate, you can determine anyone's heart rate, but not necessarily pulse rate will be equal to heart rate. Okay, there might be a case or there might be a condition where the heartbeat may not generate a pulse, right? Where the heart is beating, but that impulse is not coming to your radial pulse. That might happen, right? So this is why we also need to calculate the heart rate as well from an ECG, right? So how to calculate heart rate from an ECG, how to calculate rhythm, how to calculate axis, these are the basic things to know from an ECG, right? So how to calculate heart rate? The simple rule is the ECG paper strip that emits from the ECG machine, the rate is at 25 mm per second, right? So from the ECG machine, paper emits at a rate of 25 mm per second, right? And we calculate heart rate in the unit of beats per minute, right? Beats per minute. So if the paper strip travels at a speed of 25 mm per second, okay? So in complete 1 minute, 60 into 25, that is 1500 mm per minute, right? Okay, and from an ECG, you need to calculate the RR interval. Okay, although I am showing some abnormal ECGs. So see here, this is lead 2 tracing, right? This is lead 2 tracing. So what you need to do, you need to calculate the number of small squares between two adjacent R wave. Okay, so take adjacent R wave. So this is R wave, this is R wave of next beat. So PQRST, again PQRST, again PQRST, PQRST. So ऐसे करके you have the long lead 2 tracing, right? So this one is lead 2. So can you calculate how many small squares are there between two adjacent R waves? So let us see this. This one is one R wave and this one is another R wave. So you see at least 3 big squares. Okay, 3 big squares, and each of the 3 big squares is having 5 small squares, right? 5 small squares. So 15 small squares. Here I guess it is 3. So 15 plus 3, 18, and here 1, 19. So 19 small squares between this R and this R. Clear? Okay. So if I draw it like this, so here is one R wave and here is another R wave, and you need to calculate the number of small squares between. Okay. The number of small squares between these two R wave. So this is R1, say for example this is R2. So in between R1 and R2, you need to calculate number of small squares, extremely small squares. Okay, so here you see there are three large squares, and each large square is containing 5 small squares. Okay, horizontally. Each large square is containing 5 small squares. So 15 small squares, here is 3 and here is 1. Okay, so total 19 small squares here in this ECG, in this person. ये किसका ECG है मुझे नहीं पता, लेकिन of this patient. Okay, right? So there are 19 small squares between two adjacent R wave. Okay, and now the formula is 1500, that is 1500 divided by the number of small squares. Okay, so 1500. How do you get this 1500? I already explained. The ECG paper strip is exiting or emitting from the machine at a rate of 25 mm per second. Okay, so how much the paper will travel in a minute? That is 60 seconds. 25 into 60, that is 1500 mm. Okay, so 1500 divided by RR interval in terms of small squares. So here in case it is 19 small squares. So heart rate will be 1500 divided by 19. Okay, whatever the value will come. Okay, so for the sake of our easier calculation, take it as 20 small squares. So 1500 divided by 20 small squares. So heart rate is 75 per minute. Getting my point? This is how you need to calculate heart rate, right? Okay, so conventionally we do ECG when the paper strip emits from the ECG machine at a rate of 25 mm per second. This is convention. But you can change that setting in an ECG machine. You can also run the ECG machine at a speed of 50 mm per second. Okay, you can also run the ECG machine at 50 mm per second. So what will happen? What will be the change in formula in that case? If you run the ECG machine at a rate of 50 mm per second, what will happen? This adjacent R wave, they will be more spacious or more condensed. If the paper emits faster, okay, normally the paper is emitting at a speed of this, but if I increase the rate the paper is exiting from the machine, what will happen? R waves will be more spacious, okay, because the time between 2 bits, the paper will emit more, so that the space between 2 adjacent R wave will increase, right? Okay, so you are just doubling the speed of the paper emitting from the machine, right? So if I double it, what will be the reflection in the ECG paper strip? So in our example, it was 20 small squares, right? 20 small squares. But now the R wave will be more spacious, right? Now here is the R1, okay. As the speed of the paper is doubled up, number of small squares in between will also be doubled up, right? So previously it was 20 small squares, now it will be there are 40 small squares in between. But the formula is also changed because the paper is emitting at a rate of 50 mm per second, and in a minute it is 50 into 60, that is 3000 mm per minute. So your formula is now 3000 by RR interval. So that is 3000 by 40. Again you have same heart rate, 75 per minute. Getting my point? Okay. You are just increasing the speed of the paper, but the patient's heart rate is same. Patient heart rate is not doubled up, right? Getting my point? So when the paper is emitting from the machine at a rate of 25 mm per second, your formula is 1500 divided by heart rate. And this is convention. Every time, whenever you see ECGs in ward, ICU, everywhere, this is the convention. The ECG paper runs at a speed of 25 mm per second. So conventionally, your formula is 1500 divided by number of small square. Okay, 1500 divided by number of small square, and that is the heart rate. Okay, sometimes you may face situation like this, 1500 by, say for example, there are 17 small squares. Okay, 17 small squares. So you may get a result like this, 83.33333. So what is heart rate? Heart rate is 83 or 84? Okay, heart rate is 84, right? So 84 per minute. Okay, you neglect the decimals and take the next digit, right? Take the next digit, heart rate, as heart rate, right? Okay. Now in this regard, another question that may appear, right? So you can ask me the question, okay? You should have asked that question, which should come to your minds, that sir, this is R wave, this is R wave, so R1, R2, R3, R4, R5, R6, R7, ऐसे करके R12, ठीक है? So there are numerous R wave, okay? And I told you that take two adjacent R wave, R1 or R2, and measure the interval between. R2, R3, measure interval between. R11, R12, measure interval between. Okay, so Rn and Rn plus 1, you take interval between. Now you will ask me, sir, which RR interval should I take? Whether R1 and R2 or R2 or R3 or this R7 or R8 or R11, R12, you can ask me. Okay, and you can also ask me, sir, in this ECG, if I calculate R1 and R2, there are 20 small squares in between. If I calculate R2, R3, there are 19 small squares in between. If I calculate here, right, there are 17 small square in between. So what should I take? 1500 by 17 or 1500 by 18 or 1500 by 19 or 1500 by 20? What? Okay, so answer is take any RR interval. Okay, take any RR interval. Okay, and calculate your heart rate. Okay, there is no issues. But you can ask me this thing. So if RR interval is different, sometimes heart rate is 1500 by 19, sometimes heart rate is 1500 by 20, that is 75, sometimes heart rate is 1500 by 17, that is 83, okay, whatever. So patient's heart rate is basically changing, okay, it is not fixed, right? And that is good, okay. Your heart rate should not be fixed, right? You cannot have someone whose heart rate is fixed at 72 per minute. Everywhere you take 72 per minute. So if you know the small squares are 20, so 1500 by 20 heart rate is 75. Okay, you will probably you will not see any patient whose heart rate is fixed. So every time if you calculate R1 and R2 75, you calculate R2, R3 in between 75 square, you take R11, R12 75 small squares. Okay, it usually do not happen. Okay, it usually does not happen, right? Someone's heart rate is fixed. Our heart rate keeps on changing. Okay, and this is called your heart rate variability. Okay, heart rate variability, and heart rate variability is a normal thing. It's a normal phenomenon. Why this happens? Because your heart rate is determined by majority two nervous systems. One is autonomic nervous system, right? It has got a sympathetic component and it has got a parasympathetic component. Your sympathetic component, it tries to increase your heart rate, and the parasympathetic component, it tries to decrease your heart rate. So there is always a tussle between sympathetic system and parasympathetic system, right? Okay. Sometimes sympathetic system wins, sometimes parasympathetic system wins. So that is why this balance is normal thing. Okay, this balance is a normal thing. But there is a problem when someone dominates. When sympathetic system dominates, when parasympathetic system dominates, there is a problem. That balance is a normal thing. So your heart rate should fluctuate. Okay, your heart rate should fluctuate. This is because the interplay between the sympathetic system and parasympathetic system, and this is simply called heart rate variability. And sometimes this heart rate variability is measured as an index of stress, as an index of autonomic dysfunction, right? Very often we perform heart rate variability of a patient, okay? Mostly we suspect when we suspect autonomic neuropathy, right? Autonomic nerve disturbances, we consider it is basically a component of autonomic nervous system examination. When you are to examine a patient's autonomic nervous system, it is a component. We check heart rate variability. Okay, the more the heart rate variability, it is good only, right? When the heart rate variability is lost, that means there is some autonomic dysfunction, right? And we need to rule out the cause of this autonomic dysfunction, and we need to treat the patient accordingly, right? Okay, so heart rate variability is a good thing. Okay, so sometimes patient's heart rate is 75, in the next bit it is 76, in the next bit heart rate is 72. So heart rate keeps on moving between 72 to 78. It is a normal thing, right? There is no major fluctuation. Sometimes it is 72, sometimes it is 100, okay, sometimes it is 40. There is no major fluctuation, but within the short range, say for example, within 72 to 80, the patient's heart rate is fluctuating. This is a normal thing, right? And this is called heart rate variability. Okay, so the first thing what we need to see from the patient's ECG is the heart rate. Okay, and you need to calculate heart rate simply by putting the formula 1500 divided by RR interval in terms of small squares, number of small squares, right? So next point is rhythm. How to check the rhythm? Okay, so look for the P wave, whether P wave is present or not. So P wave is present, so we call it sinus rhythm. As the source of P wave, it is coming from SA node only, right? Okay, so when you see the P wave in the ECG, so it is sinus rhythm. So there are different other types of rhythm that we will discuss under the class of arrhythmia or rhythm disturbances, right? Okay, so rhythm is sinus. Just interpret a normal ECG. Just right now, just try to interpret a normal ECG, because there are so many abnormalities that we will discuss in our subsequent classes. Okay, so now the axis. So you have got the idea of axis. In my previous class, I have told you the mean electrical axis. Okay, the mean electrical axis, which is mostly oriented towards lead 2, and the normal range of cardiac axis is minus 30 to plus 110, or in some books it is also written as plus 100. So okay, for our discussion, let us consider it minus 30 to plus 110. Minus 30 to plus 110 is the normal range of axis. Okay, minus 30 to plus 100. Okay, so for this, let me draw a picture. Okay, the accurate actually axis, ECG axis, is a very important thing that we need to check while seeing the ECG strip of a patient. Okay, so that gives you the result as either normal axis, or either left axis deviation or right axis deviation. Okay, so it might be normal axis, it might be left axis deviation, or it might be right axis deviation. Okay, so let me draw this. So this angle is, this is lead what? Which lead? Lead? Yes, lead 1. This is lead 2. This is 3. Okay, this is AVF. This is AVL. This is AVR, right? This angle is 0 degree. This is 60 degree, plus or minus? Plus. Plus 60 degree. Plus 90 degree. And here it is minus. What? Minus 60. Okay, so tell me the range of normal axis. Normal axis? Minus 32 plus 110. Okay, so whenever your mean electrical axis falls within this range, the axis is normal. Okay, what is mean electrical axis? May I ask you, what is mean electrical axis? What is mean electrical axis? What is mean electrical axis? Do you remember the vectors? No. देख के तो बताओ at least. Okay. So very fast recap. This is your heart, right? First, the atrial depolarization vector. Second vector is the septal depolarization vector. Okay. Third vector is apical vector. Okay. Fourth vector is the ventricular depolarization vector. And fifth vector is posterobasal part depolarization vector. Right. Now, assuming all four ventricular vectors, this is atrial vectors, and all these are ventricular vectors. Okay, all these are ventricular vectors. V1, no, not V1, because these are not leads. Okay, so ventricular vector 2, 3, 4, 5. So if I combine this 2, 3, 4, 5, we get a resultant vector. Okay, we get a resultant vector. So this resultant vector is this. Okay, this resultant vector is called mean electrical axis. Okay, this mean electrical axis is the resultant of 2, 3, 4 and 5. Okay, 2, 3, 4 and 5, and the direction of this 2, 3, 4 and 5 in a healthy individual, it should be within this area, right? It should fall within this. Okay, it should fall within this. Matlab -30 to +110. Okay, this mean electrical axis should fall within -30 to +110. We call it normal axis. Okay, we call it normal axis. So this axis basically depends on many things. Say for example, the ventricular muscle mass. Okay, the ventricular muscle mass. So I told you that we need a stronger vector to depolarize a strong muscle, right? So now let us take an example. So you have this right ventricular free wall, right? This is right ventricular free wall. This is interventricular septum, and this is your left ventricle, right? This is right ventricular free wall, this is left ventricular free wall. Now tell me which is thicker? Left ventricular free wall is thicker, and this is why your mean electrical axis is oriented towards left. Okay? Your mean electrical axis is oriented towards left because stronger depolarization vectors are working in the left ventricle, right? This is why your mean electrical vector is deviated towards left, right? Otherwise, ये दोनों अगर सेम होता तो क्या होता? It should have oriented towards this in the midline according to the septum, because both the side you have equal muscle, right? Now take a condition where right ventricular muscle is more. Okay, create that situation. How to create right ventricular hypertrophy? Right ventricle pumps blood into which circulation? Pulmonary circulation. Okay, so let us increase your pulmonary vascular resistance. Okay, let us increase your pulmonary vascular resistance. Okay, and what will happen if your pulmonary not your, of a patient, okay. So take a patient whose pulmonary vascular resistance is high. Take a patient whose pulmonary vascular resistance is high. What will happen? So previously you used to lift 10 kg dumbbell. Now I am asking you to lift 20 kg dumbbell. Okay, so your right ventricular muscle was lifting 10 kg weight. Now you are directing your right ventricle to lift 20 kg weight. Okay, what will happen? Right ventricle will get thicker. Okay. If this happens, how are you doing that? You are increasing the pulmonary vascular resistance because your right ventricle pumps blood into pulmonary circulation, right? Your right ventricle pumps blood into pulmonary circulation and you are increasing the resistance here, right? So your right ventricle muscle is working more, okay, against a high resistance. Previously it was lifting 10 kg dumbbell, now it is lifting 20 kg dumbbell, right? Okay, now your right ventricle is getting hypertrophied. Okay, the right ventricular muscle is thicker now. Okay, so what will happen to this mean electrical axis? Yes, it will rotate. This mean electrical axis, this will move, right? So clear? So mean electrical axis will rotate towards right, okay, and if it crosses this dotted line, okay, if it crosses this dotted line here, say for example, we will call it right axis deviation, okay. Similarly, your left ventricle is already thick, but if systemic vascular resistance is high, your left ventricle will get thicker, right? Your left ventricle will get thicker. Your left ventricle is already thick, but it may get thicker as well, right? Then what will happen? Yes, then it will rotate like this, okay? So this is called left axis deviation. So for left axis deviation, the axis should rotate beyond minus 30 degree, right? And for right axis deviation to happen, the axis should rotate beyond plus 110 degree, okay? So normal axis is minus 30 to plus 110, okay? यहाँ पर beyond minus 30 is left axis deviation and यहाँ पर beyond plus 110 is right axis deviation, okay? So from this example, at least you can tell one cause of left axis deviation and one cause of right axis deviation. So tell me one cause of left axis deviation and one cause of right axis deviation. At least one cause you can tell. The cause of right axis deviation is right ventricular hypertrophy. Okay, right ventricular muscle mass is more. And the cause of left axis deviation is left axis deviation. But yes, it is correct. The cause of left axis deviation, cause of right axis deviation is right ventricular hypertrophy. But the cause of left axis deviation is not always left ventricular hypertrophy. There are other causes as well that we will discuss in subsequent classes, right? There may be blocks, okay? There may be conduction blocks that may create left axis deviation, particularly left anterior hemiblock, okay? So anyway, left ventricular hypertrophy is also another answer. The commonest cause of right axis deviation is right ventricular hypertrophy, and the commonest cause of left axis deviation is left anterior hemiblock first, and second is left ventricular hypertrophy. Okay, chalo. So हमने क्या क्या देख लिया? Number one, we have learned how to calculate heart rate from an ECG. We have known what is ECG rhythm. Now we are seeing the ECG axis, rate rhythm axis, right? Next we will see P wave, whether P wave is normal or not, okay? So P wave, usually we do not measure the duration of P wave, but often we measure the height of the P wave. It usually do not cross more than 2 small squares. It usually do not cross more than 2 small squares in an ECG. You know, 2 small squares in the vertical axis means how much millivolt? In the ECG, this is a graph, right? This is a graph. This x-axis is time and the y-axis is voltage, right? So in x-axis, 1 small square is 0.04 second. Okay, in y-axis, 1 small square is 0.1 millivolt. Okay, so P wave usually 2 small squares in height. That means what is the voltage of P wave? If I ask you what is the voltage of P wave, if it is 2 small squares in height, 0.2 millivolt, simply 0.1 into 2, that is 0.2 millivolt, right? So now there might be abnormalities in the P wave. P wave might be more than 2 small squares, okay, more than 2 small squares, or sometimes P wave might be notched. So there are various abnormalities in P wave that we'll discuss in subsequent classes. Okay, we call it P mitrally or P pulmonally accordingly. Okay. So after P wave, we can calculate the PR interval. Okay, abnormalities we will discuss later on. Right now, just interpret a normal ECG. Okay, so PR interval. What is PR interval? I told you that PR interval is from the start of the P wave to beginning of Q wave. PR means not P and R. PR means P and Q. Okay, so from the start of again see the lead to long tracing. So start of P wave is this point and start of Q wave is this point. Okay, from the beginning of P to start of Q. Okay, from the beginning of P to start of Q, let me draw a large ECG complex over here. So P, right? So this one is P and this is the beginning of Q, right? Now you calculate these small squares in between. Okay, so 1, 2, 3, 4, 5, 6, 7 small squares. Okay, 7 small squares, correct? Between, from the beginning of P to beginning of Q, 7 small squares. So if there are 7 small squares between in the PR interval, okay, start of P to beginning of Q, there are 7 small squares. So what is the duration of PR interval? Point 0.28 second. Very nice. How did you get it? 0.04 into 7, right? So that is 0.28 seconds. Clear? So this is how we calculate PR interval. Do you know what is the significance of PR interval? What does it signify? What does it signify? P wave is for, P wave क्यों होता है? Atrial depolarization. QRS complex? Ventricular depolarization. So PR interval means? Yes, atrial depolarization के बाद ventricular depolarization होने में जो interval है वो क्या है? So your action potential is being generated from SA node, right? And it travels through the interatrial, in between SA node and AV node, internodal tract, and enters into ventricle. So this time duration, okay, from SA node to AV node, okay, जहाँ से generate हुआ action potential, वहाँ से atria से ventricle आने में कितना time लगता है, ठीक है? Getting my point? This is the time for PR interval. So we check PR interval and we get an idea how faster your atrial depolarization travels into the ventricle. Correct? Getting my point? Because P wave is atrial depolarization and QRS complex is ventricular depolarization. The time interval between atrial depolarization and ventricular depolarization is the time that tells you how faster atrial depolarization comes into ventricle. The traveling time of action potential from atria to ventricle. Getting my point? Clear? Okay. And the normal duration is normal duration is 0.12 to 0.2 second. Okay, 0.12 means how many small squares? 3 small squares. 0.2 means how many small squares? 5 small squares. Okay, so there should be 3 to 5 small squares in the PR interval. In our example, it is 7 small square. That means PR interval is increased. Okay, PR interval increased. That means the action potential which is being generated in the SA node, it takes more time to reach into the ventricle. Right? And this is abnormal. Okay, and this is abnormal. Okay, and this is called heart block. Yes, AV block. When PR interval is increased, we call it AV block. There are further classification of AV block. It may be first degree block or second degree block or third degree block, right? Okay, I will discuss in our next class different classification of, yes? Yes, AV nodal delay is buried within PR interval. Okay. No. Okay. So this is called PR interval, and PR interval gives you the time the atrial depolarization travels to ventricular depolarization. Okay. It also includes the AV nodal delay. Okay. Clear? Okay. So when PR interval is increased, that is more than 0.2 second, so there is a block. Okay, there is a block. We don't know where the location of the block is, but definitely there is a block. Okay, so PR interval you need to note. In normal, it should be 0.12 to 0.2 second. Very important question, frequently asked in the Viva examination. How much is the normal interval of, how much is the normal time of PR interval? Okay, very frequently it is asked. Normal PR interval duration. Okay, now after PR interval, we see the QRS complex. You need to check the QRS complex. Okay, so QRS complex, there are many things we see in QRS complex. Okay, we will discuss gradually what are the points that we see in QRS complex. We see the duration of QRS complex, that should be usually less than 120 milliseconds. Okay, usually less than 120 millisecond. That is 120 millisecond means how many seconds? .04 second is equal to how much millisecond? 40 millisecond. One small square is equal to 0.04 second. That is equal to 40 millisecond. Okay, 40 millisecond. And ideally, this QRS duration from here to here. Okay, this duration should be within 120 millisecond. 120 millisecond means 40. That means 3 small squares. Okay, 0.04, 0.04, 0.04. 3 small squares. If it is longer than 120 millisecond, then we call it wide complex. Okay, and normally your QRS complex should be a narrow complex. That means less than 120 millisecond, less than 3 small squares, right? Okay, we also check ventricular hypertrophy criteria. We have also ventricular hypertrophy criteria for by seeing QRS complex. Okay, by seeing simply QRS complex, you can check whether there is left ventricular hypertrophy or not. Okay, so we calculate it. There are various criteria. One criteria you can remember, that is SV1 plus RV5. Okay, SV1 plus RV5. So you check V1. This is V1. And this is S wave of V1, right? S wave of V1. So you calculate the downward height of V1. How many small squares are there? So 1, 2, 3, 4, 1, 2, 3, 4. So 4, 4, 8 small square down. V1. Okay. 8 small square down. And what are V5? V5, dekh lo. So this is V5. V5 ka upward deflection kitna hai? So again, this 5 total. And this 1, 2. So 5 plus 2, that is 7. So plus 7 and here minus 8, minus 8 plus 7. Okay. So total is 8 plus 7, that is 15. Okay. If it is SV1 plus RV5, if it is more than millivolt, it is a criteria for left ventricular hypertrophy. Okay, it is a criteria for left ventricular hypertrophy. If it is more than 35, okay, if it is more than 35, that means 3.5 millivolt. 35 small square means 3.5 millivolt. Clear? Because 1 small square is equal to simply 0.1. Okay. Okay, so we check the progression of R wave, the duration of QRS complex, and we also check the voltage criteria for ventricular hypertrophy under QRS complex. And next is ST segment. Okay, what is ST segment? This one. This one is ST segment, and you see there is no fluctuation during this ST segment. There is no voltage fluctuation, it is in the baseline. Okay, you check this, this is baseline. Okay, why does this happen? Anyone? Why does this happen? There is no voltage fluctuation during ST segment. It is an isoelectric line, we call it isoelectric line. Okay, this is ST segment and we call it isoelectric line. Why this is isoelectric line and why there is no voltage fluctuation, no net electrical flow within this time? We are getting what is the ST segment? This area is ST segment. Okay, ST segment, and this ST segment should be isoelectric. Why? Okay, see this picture. Okay, see this picture. This is ST segment, clear? This one is ST segment. Why this is isoelectric? Because of this play to phase. You remember ventricular action potential, the black line? See the black line now, not the red line. Red line is abnormal ECG, right? So if I superimpose ECG and ventricular action potential in the same time frame, okay, if I superimpose ECG tracing with the ventricular action potential in the same time frame simultaneously, so we see that this play to phase in the ventricular action potential, you see the phase 4, phase 0, phase 1, this is phase 2, right? If you remember, this is called fast response action potential. Okay, this is called fast response action potential. In the fast response action potential, this ST segment corresponds to phase 2, and in phase 2 there is no net flow of electricity. Because there is no net flow of electricity in phase 2, this is because the positive ion enters and positive ion exits. So they balance each other, right? There is calcium entry and potassium exit that happens simultaneously. So this is why there is no net electrical flow during phase 2 of ventricular action potential. As a result, in the ECG signal, we get ST segment, which is isoelectric. Okay? This is why it is isoelectric. That means you do not get any upward fluctuation and you also do not get any negative fluctuation. Okay? You get a simply baseline during phase 2 of ventricular action potential, and it is reflected in ECG as ST segment. Okay? Clear? Any confusion? Okay. So ST segment should be isoelectric. Now, ST segment. After ST segment, what do we see? We see the T wave. Okay. Again, T wave has got much abnormalities. It may change in myocardial infarction, acute coronary syndrome. There are changes in the T wave height changes. There might be T wave inversion, and also T wave changes in electrolyte disturbances. Okay. In hyperkalemia, it is picked up. in hypokalemia it is flattened. Okay, so that we will discuss the abnormalities of T wave in subsequent session, right? So you also check whether the T wave is normal or not. Sometimes T wave inversion is normal. Say for example in your lead AVR. In lead AVR, T wave is always inverted. Okay, lead AVR, T wave is always inverted, and T wave inversion is also common in chest leads, right? But you check whether the T wave changes, the changes in T wave are happening in the ambiguous lead or not. That I'll discuss in subsequent time, right? So next we need to check the T wave. Again, I'm recapping. First you need to check the rate, then heart rate, then rhythm, then axis, then P wave, then PR interval, then you need to check the QRS complex. Or under QRS complex, you need to check the duration of QRS complex, the flow of R wave. Okay, this is not normal ECG. If I get one normal ECG, okay. Anyway, you see from V1, see V1, V2, just check the QRS complex. In lead V1, you see the QRS complex is majority downwards. Clear? In V2 also it is downwards. V3 upward, downward, more or less same, right? In V4 upward deflection is more than the downward deflection, and V5 it is upward deflection predominantly. V6 it is upward deflection predominantly, right? So this is how the R wave progress from V1 to V6. In V1 and V2 it is majority downwards QRS complex. In V3 V4 50-50s, कुछ ऊपर है कुछ नीचे है, right? V3 V4 and V5 V6 it is majority upwards. So this is how R wave progress. So we call it normal progression of R wave. So whenever you are checking QRS complex, you check the QRS complex duration, right? You also check the voltage criteria for ventricular hypertrophy, and you also check the R wave progression. And under ST segment, you check whether the ST segment is isoelectric or not. Okay, isoelectric or not, because there might be cases of ST segment elevation or ST segment depression. Okay, ST segment elevation or ST segment depression. The cases might happen. Simply, here you see the ST segment is depressed downwards. Can you check? In lead 3, ST segment is downwards. Again, I will show more ECGs. You see, ST segment is upwards. This is the baseline, right? And ST segment is above. Here you see, ST segment is above. ST segment is above, right? So this is a case of ST segment elevation. Okay, these are abnormal ECG. I am not discussing abnormal ECG today. We will not understand, right? So these are all ECGs of acute coronary syndrome or myocardial infarction that we will discuss in subsequent classes, right? Okay, so you need to check whether the ST segment is isoelectric or not at the baseline or not. Okay, if it is isoelectric, it is normal. If ST segment is elevated or ST segment is depressed, there might be some abnormality and you need to evaluate the patient, right? Okay, so after ST segment, you need to check the T wave, whether the T wave is flat or T wave is inverted or T wave is hyperacute. Okay, T wave is taller than what it is expected, right? Okay, than what it is supposed to be, right? So check the abnormalities of T wave as well, and finally the QT. Okay, QT. Okay, so what is QT? From the beginning of Q to end of T. Okay, from the beginning of T to end of T. So from this point to this point. This is QT. So can you tell me, not QT, QT, right? Okay, anyways. So QT means which time? It is a time interval, right? It is definitely a time interval. Just like PR interval, QT interval is a time interval. So what does it signify? Just like your PR interval, it tells how faster your atrial depolarization travels to ventricle. How much time it requires to travel to ventricle from atria, PR interval. So similarly, what is the significance of QT interval? Yes, the ventricular depolarization plus ventricular repolarization. आपका ventricle depolarize होके फिर repolarize होने में कितना time लगता है, right? So you have checked this action potential, okay? So depolarization plus repolarization, this total duration is the QT interval, okay? So आपका ventricle charge होके फिर discharge होना, so this time interval is QT interval, and we measure this QT interval because very often there are some diseases where QT interval is increased, okay? QT interval is increased and we call it, okay, QT interval is increased. So before that, check how much should be the QR interval. QR interval means within this QT you need to check the number of small squares, right? Number of small squares, okay? So if there are 10 small squares between from the beginning of Q to end of T, so it is 0.4, right? And if it is in millisecond, 400 millisecond, right? Okay, now one thing, to standardize this instead of QT interval, because if you change the heart rate, the number of small squares between Q in the QT interval will change, okay? So to standardize this, actually what we measure instead of QT interval, we measured QTC, or we call it corrected QT interval, okay? QT and there is a small c, and corrected QT interval is equal to QT interval divided by root over RR interval, right? This is called corrected QT interval, and you know that QT interval denotes the ventricular depolarization plus ventricular repolarization, this total time, okay? This total time is called QT interval, and we measure, what we actually measure is the QTC, corrected QT interval, and the formula is QTC is equal to QT interval divided by root over RR interval in millisecond. Everything is millisecond, okay? And when it is more than normal, okay, you need to also remember there is no fixed QT interval, there is a range, okay? There is a range 360 to 450 millisecond QTC interval, right? Okay, if it is say for example beyond something 500 millisecond or something like that QT interval, then it is definitely abnormal, okay? And there are many causes of long QT, okay? There are many causes of long QT, and mostly these are different channelopathies. What are channelopathies? Channelopathies are defect in the ion channels. You know, for this ventricular action potential to happen, you need a calcium channel, right? You need a calcium channel, you need potassium channel, very different types of potassium channel, right? You have seen, right? The sodium, voltage gated sodium channel, calcium channel, potassium channel. There are role of many channels responsible, they are responsible for this fast response action potential, right? So what happens in LQT? LQT means long QT, okay? And the disease is called long QT, saturation, na? Disease is called long QT syndrome, and it is due to defect in the ion channels. And one of the important example is Brugada syndrome, okay? Brugada, Brugada syndrome. It is also due to a defect in the ion channel.